So, hello everyone. Welcome to the newest installment to the TSC educational series. We're March 20th, 2025, as the slide says. So I'm Dr. Mark Keyser. I'm a neurologist at the CHUM in Montreal, University of Montreal Health Center, and I am the director of our TSC clinic for adults. And so today I have the great pleasure of presenting Kristen Mohler, who is a colleague of ours at the CHUM, who is a genetic counselor. And a topic that I think, especially on the adult side, is one that's easily neglected. And so I'm very glad that she's here to talk a little bit to us. In title of her talk, you see here, genetic counseling and family planning in TSC, tuberous sclerosis. Um, Please, I leave it to you, Kristen.
Thank you. Perfect. So I'm gonna make this full screen. So now do you see the presentation in full screen?
I do, yes.
Yeah. Okay, perfect.
Perfect.
So I don't see you anymore. So if there's anything, any technical issues, you need me to stop for any reason, just holler, just let me know. So thank you so much for having me. My name is Kristen. I'm a genetic counselor as well at the CHUM in Montreal. And so I've divided my presentation today into two parts, the genetic counseling portion and the family planning portion. And for sure, some of the concepts will be a bit more abstract. I'm going to do my best to explain them, but if there's anything that's not super clear, I have no issue, answering questions during the didactic period as it pertains to, the slide that I'm on. So feel free to stop me. So let's start with the genetic counseling portion. So a bit of genetics 101, the basics of genetics. So in every cell in our body, we have DNA, and the DNA is split into different sections that are called genes. And all of us, we have over 20,000 genes, and they all play, a different role in our body in its growth, development, regulation, etc. And so when there's an error in one of these genes, or what we call a mutation, it can cause a genetic condition like tuberous sclerosis. And so speaking more specifically about that, there are two genes that are known to be involved in TSC, appropriately named TSC1 and TSC2. And so you can see here that TSC2, makes up a greater proportion of TSC, with about 70% of cases attributed to this gene, to mutations in this gene, I should say, and about 25 attributed to mutations in TSC1. There's about 5% of cases that remain, with an unknown cause, so that where we don't find a specific mutation in TSC1 or in TSC2. And this is a point that I'll come back to later, so just keep that in mind. So if we talk a bit about the heredity of the condition, we know that it's transmitted in what we call an autosomal dominant manner. So if we talk a bit about what this means, we know that everyone has two copies of each gene. One copy that comes from our mother, one copy that comes from our father. So technically, all of us, we all have two copies of TSC1 and two copies of TSC2. And for people who are affected with TSC, there will generally be a mutation in either TSC1 or in TSC2. So meaning that one of their two copies of either of the genes is mutated and the other one is quote unquote normal. So for the sake of, example, let's say that a person who's affected with TSC has a mutation in TSC2. So they have one copy of TSC2 that has a mutation, the other copy that's normal. So every time that this person has a child, they will pass on one of their two copies of TSC, either the copy with the mutation or the copy that's normal. And it's completely random. So that means that each of their children will have a 50% probability, or a probability of 1 in 2, of inheriting the copy with TSC with the mutation, and 1 in 2 probability of inheriting the copy without the mutation. And so those who inherit the copy with the mutation will be affected similarly. So that's a bit about the heredity. There's another quick concept that I wanted to touch on. It's called mosaicism. It's not something that's uncommon in TSC, so that's why I wanted to talk a bit about it today. So the concept of mosaicism is basically the presence of two distinct cell populations within an individual. So if we look at this image here, I don't know if you see my mouse, the image on the top right. The mosaic tissue is made up of two different cells. So let's say that the orange,
$47,000 per year.
so let's just say that the orange circles are quote unquote normal cells, and the green circles are the cells that have a genetic change. And so within this person, they have both the cells that are normal and the cells that have the change. So that means that the orange cells have, let's say, two normal copies of both TSC1 and TSC2, but the green cells have a copy that has a mutation. And so subcategories of mosaicism, there's somatic mosaicism, which means that there's the presence of two distinct cell populations within an individual. And generally, when we're talking about somatic mosaicism, it means that the reproductive cells are usually not affected. So the mutation is not present in the reproductive cells, and therefore the mutation is not passed on to the children. On the other hand, in germline, or sometimes called gonadal mosaicism, it's actually solely the reproductive cells that carry a genetic mutation that the other cells in the body do not carry. So technically, this person is not affected with the condition, but they could transmit it to their children because their reproductive cells, either their sperm or their ova, have the mutation. Okay. And so if we talk a little bit about recurrence risk, it'll vary depending on these kind of two categories. So in the de novo category, this means that the genetic mutation occurs for the first time in the child, in the individual, and it's not inherited from one of the parents. And this is about 2/3 of cases of TSC. And so we see here the two parents are unaffected, the child is affected. Well, the recurrence risk, so that's, the probability of these two people having another child with tuberous sclerosis, we wouldn't say is 0, because there is the possibility of germline or gonadal mosaicism. So the recurrence risk actually is usually estimated about 2 to 3%, because even if we do a genetic test on the parents, looking for that mutation that was found in the child, and we don't necessarily find it, we can exclude that that mutation is solely present in, let's say, the father's sperm or the mother's ovum. In the other category, the inherited category, the genetic mutation is passed down from parent to child. And so we can see here the father is affected and the son is affected. And inherited TSC makes up about 1/3 of cases. And in this case, we'll go back to what we learned in one of the first slides, autosomal dominant transmission. So we know that the recurrence risk is 50%. So we can jump into the family planning portion now and talk about reproductive options. So this slide kind of just gives an overview of some of the reproductive options, and we can go through each one individually. So for those who choose to have a natural conception and natural pregnancy, there's different possibilities of testing the child or finding out if the child is affected with TSC or not. The first option is, having the pregnancy, going through with the whole pregnancy, having the child being born, and having the child be evaluated by a geneticist or a neurologist or another specialist in infancy. That's, if we don't want to know beforehand, if we don't really care about knowing before giving birth. And the second option kind of goes hand in hand with that. There's a possibility of a genetic test once the child is born as well. The next option falls under the category of natural conception. It's the possibility of prenatal diagnosis, which is something I'll go into a bit more detail later on in the presentation. And then there's the possibility of pre-implantation genetic testing, something I'll also talk about shortly. And then, of course, there's the option of adoption, and there's the option of gamete donation. So if we know that the father is affected, we can get a sperm donation. If we know that the mother is affected, we can get ova donation. And so these three options are, only available for those who have a known genetic mutation. So when there's an identified mutation in the family. And so when we're in that, 5% unknown category, unfortunately, these are not necessarily something that could always be offered. So if we talk a bit about natural conception, there's certain things to keep in mind. So the first thing is, what is the probability of having an affected child? And for those, for example, who are affected, we know that the risk is 50% for each pregnancy. And then in other situations, the probability might be different, as I, discussed previously, depending on if it's de novo or whatnot. And then there's some other considerations to keep in mind for a woman who is affected with tuberous sclerosis, who plans on being pregnant. There might be risks, for her health just based on having the condition and being pregnant. And then there's also the risks and benefits of using certain medications during pregnancy. And so those are, out of my wheelhouse personally, but definitely something to discuss with a doctor, before planning the pregnancy. So now we can talk a bit about prenatal diagnosis, something a bit more in my wheelhouse. Within prenatal diagnosis, there are two options: chorionic villi sampling and amniocentesis. They kind of follow the same concept, which is that we'll have a natural conception, so the woman will get pregnant naturally. And then the goal of the prenatal diagnosis is to know before giving birth if the child is affected with tuberous sclerosis or not. There might be, multiple different goals of doing this kind of testing. One of which might just be, to know beforehand so we can prepare for when the child is born, if there are any, specific health implications that we need to look for at birth. Some people might also have like extra follow-up if we know that the child is affected, fetal MRI or echocardiograms as well during pregnancy might be indicated. And then the other reason is for those who do not wish to have a child who's affected. If we can do the test beforehand, do prenatal diagnosis beforehand, then we can know if the child is affected or not. And some people might choose to terminate the pregnancy at that point. And so the two different options of prenatal diagnosis are chorionic villi sampling or amniocentesis, as I mentioned. With CVS, it's usually done a bit earlier in pregnancy, between 11 to 13 weeks. And the test that we do, the genetic testing, is on the DNA from the placenta. And then for amniocentesis, it's done a little bit later, about 15 to 16 weeks of pregnancy. It will depend what center, what hospital center you're going to. And the genetic testing is actually done on DNA from fetal cells within the amniotic fluid. So the concept is using an ultrasound and a needle, we'll take a sample, again, in CVS, either from the placenta or an amniocentesis of the amniotic fluid, and we'll do the genetic test on those samples, looking for the specific mutation that's known in the family. For prenatal diagnosis, for the CVS and for the amniocentesis, the genetic testing reliability is close to 100%. And there are some considerations to keep in mind, though. So the risk of miscarriage for both procedures, because they're considered invasive procedures, there's a risk of miscarriage of about 1 in 300. And so that's why sometimes a thought that people who are considering this will have is, if I'm not going to terminate the pregnancy, if the result is positive, then I don't want to risk putting my pregnancy at risk of losing the pregnancy. So these are all, things to keep in mind, but at the end of the day, it will be a personal decision for each person. Another thing to keep in mind for this is there's a possibility that the test won't work for, various technical reasons. And so that it might need to be redone. And so the thing to keep in mind with that is that then we're pushing out the diagnosis further and further, the more testing that needs to be done. Generally, the result will be available as of 3 to 4 months of pregnancy. The chorionic villi sampling is not always something that's possible. It will really depend on the position of the placenta. And then, of course, there's a psychological or emotional impact of doing this kind of procedure. You know, it's not something that's necessarily an easy choice to make.
Kristen,
Yes.
you had mentioned questions during the presentation. There is one question if you want me to
Perfect. Yeah, in the
read it
chat.
out. Yeah. So I can read it. It's from Raymond. So could or should genetic testing for TSC be done on all newborns as is done with some other conditions? So population screening.
That's a good question. You know, there's certain criteria that we follow for like newborn screening and population screening, based on an article from quite a few years ago now. But you know, those criteria, for example, are like, you know, the frequency of the condition in the population. Is there like certain follow-ups or treatments that can be done before like symptoms appear? So there's lots of things to keep in mind for things like that. Personally, you know, I think it comes down to a lot of different things. You know, there's also like budget in that as well. Personally, I don't know off the top of my head the like frequency of the condition itself. So I don't even know if it would be something that would be considered for each, you know, province's newborn screening program. But it's, you know, a great question, and it's, you know, good forward thinking. You know, we're moving in that direction, but I don't necessarily have an answer for you, unfortunately.
And I, if you don't
Absolutely.
mind, I'd add to that. I think we were getting close, but we've probably taken a step back, because because of the science. So the prevalence is actually live birth prevalence is actually quite high. It's a common rare disease. It's 1 in 6,000 live births, and I say we were almost there because there are some trials suggesting that we could alter the natural history if you started treating them with certain medications before they developed their seizures. And that was very exciting and interesting. There was a second large study that was done where the results were not as clear. And so that's why I say that I think we were moving towards it. Now maybe we're not moving towards it as fast. But we'll see. There are 2 other major studies that are being done looking at this idea of what we can do before you even know they have TSC. You would otherwise know they have TSC before you start. Those results, I think, will influence things a lot. So if those 2 other studies show that you have to treat them before even the very first seizure appears, then I think we're all going to be pushing very hard for screening. We're not there yet. I want to say I think some places maybe already started, but I'm not sure.
Yeah, it's very possible. And I know, you know, the newborn screening like condition list is changing so rapidly all the time. And it's, you know, regulated province by province. So I'm sure as more data comes out, it's definitely things that are going to be looked at more and more, for sure. It's a great question. All right, so continuing on, pre-implantation genetic testing. So another reproductive option. In this case, it's a little bit different from the prenatal diagnosis in the sense that it's done actually before pregnancy. So the genetic test is done on a sample of DNA from an embryo that is formed by IVF. So IVF is the process of taking the sperm and the ovum and creating an embryo in the lab. And then what we'll do is we'll let the embryo develop to a certain stage, and we'll take a biopsy. So we'll take a few cells out of the embryo, depending on what stage the embryo is in. It's generally not something that's harmful for the embryo. And then we'll actually do the genetic test on the cells that we've, you know, extracted from the biopsy. And then generally the concept is that we'll implant only the embryos that are unaffected and so that don't have a mutation. And again, this is something that's only really possible when there's a known mutation in the family. So it's not necessarily possible if the cause is unknown. And so that's, you know, another way to like kind of in French, contourne, like go around the thought of like, you know, in prenatal diagnosis, we still need to have a pregnancy, there might be termination. And so that's why I say, there's psychosocial and emotional impacts versus in this pathway, but they're not really things that we need to think about and consider. Although there are, another bunch of ethical issues that people might raise with pre-implantation genetic testing. But that's, another option that's available for lots of different genetic conditions as well. And so the considerations here, the reliability is a little bit less than for the prenatal diagnosis, varies between 95 to 98%. And so often with this, given that it's not 100%, what we will do is once we do the pre-implantation genetic test and we implant the embryo that's unaffected, we'll then also offer the possibility of prenatal diagnosis once the pregnancy is, far along enough, either for like the CVS between 11 and 13 weeks or the amniocentesis between 15 and 16 weeks. So that's something that would be offered as well in order to boost that reliability a bit higher. The considerations for this: cost and waitlist. This is, something that's covered by the government in Quebec for one cycle, but it's, again, something that varies province by province. So for example, in Quebec, it's covered for one cycle. So that means basically you can do IVF one time, however many embryos you get from that, we'll test them all, covered by the government. Let's say you have a successful pregnancy, you have a child. If you want to have a second child, it's no longer covered by the government. So then there's a cost out of pocket. I don't know, the procedures for other provinces, but I would imagine, as we're moving forward, there's some that are going to be covered as well, but there's also a long wait list to be to get to this procedure as well. Again, as I said, the reliability less than 100%. There's the, possibility, would be very unlucky, but there's the possibility that by chance, all the embryos that are created and tested are affected with the condition. So there would be no unaffected embryo to implant. There are some slight, risks associated with IVF, ovarian hyperstimulation, complications during egg retrieval, etc. And it's not always something that's possible. It's more difficult for, let's say, de novo mutations, for example.
Kristen,
Yes.
another question. Why is it not possible? I think this is for prenatal testing, if it is likely de novo, but the parents want to be sure.
It's not that it's not possible. It's definitely something that's possible, but it might be more technically challenging. So again, it will really depend on the type of mutation, whatever. And, if you do end up consulting for this kind of procedure, we would be able to give you more specific, like, let's say, reliability measures for this. But it's not that it's not possible, it just becomes a bit more technically difficult. So the key takeaways from, my presentation today, there are many reproductive options available. Like I mentioned earlier, it is really a personal decision for each person, for each couple. So reflect on your family plans in advance, discuss with your partner, and talk to your doctor or request to meet with a genetic counselor to help, guide you and determine which option might be best for you. As I mentioned, there is a prerequisite for the prenatal diagnosis and the pre-implantation genetic testing, which is having a confirmed mutation in the family. Excuse me. And then, as I mentioned, if you're a woman affected with TSC, planning a natural pregnancy, be sure to talk to your doctor. Again, out of my wheelhouse, but definitely something that that needs to be discussed. So I think that covers it. A brief overview of the reproductive options and family planning. But yeah, I'd be happy to take any questions that you have. I'm gonna stop